So I'll be talking about how to choose the right antibiotic based on microbiology and pharmacology in GI infection. So, okay. So I'll be covering in these headings. I'll be discussing about acute diarrhea, cholangitis, cholecystitis, pancreatitis, and if time permits, about spontaneous bacterial peritonitis. So we begin with a case scenario. So a 30 male immunocompetent, history of 2 days of diarrhea, 7 to 8 times per day. There is no fever, no blood in stools. He's able to function, but with a change in the activities, the normal routine activities. There is a history of travel. On examination, there is no significant finding. So in this particular scenario, do you think antibiotics are needed? If yes, what and for how long? So I'll just take responses from two students. So anyone? Is antibiotic needed or not? First. So everyone agrees that antibiotic is not needed? Okay, we'll try to find the answer. So if you see acute diarrhea, the virus is the one that is most common. The common diarrhea is community acquired. Rotavirus, calcivirus, astrovirus, adenovirus. Bacterial infection, Salmonella, Campylobacter, Shigella, E. coli, Clostridium difficile. And parasites, which is Giardia and Cryptosporidium. So the things that we need to consider in patients with acute diarrhea is, one, these episodes of acute diarrhea in majority is self-limiting. So acute diarrhea is defined by diarrhea persisting for less than 14 days. So less than 14 days is an acute diarrhea. Toxin-related gastroenteritis predominantly due to staph or bacillus, you do not need antibiotics. Empirical antibiotics in general for acute diarrhea are not required. Probiotics, prebiotics again are not required for acute diarrhea. In Salmonella, antibiotics may prolong the shedding in stool, so this can happen. And antibiotic sensitivity testing with acute diarrheal infection is again not recommended. So there are scenarios where you need to do a stool diagnostic test. It is when the patient has got dysentery. So dysentery is typically when blood is associated with the stools. This is what dysentery is. Or the disease is moderate to severe. I'll come to what moderate to severe disease is. And symptoms lasting for greater than 7 days. Again, antibiotics, if indicated, usually should be given after stool culture. There are certain scenarios where you need to give empirical antibiotic, and these are predominantly the presence of fever, presence of blood or pus in the stools, immunocompromised patients, neonates or elderly, Salmonella bacteremia, cholera, traveler's diarrhea. Again, traveler's diarrhea with fever should be treated with azithromycin. Loperamide, which is an anti-motility drug, I can tell you this is a very, very important drug in patients with acute diarrhea, and this can decrease the duration of illness and decrease the frequency of stool as well significantly. So traveler's diarrhea, you find the bacterial pathogens in around 50 to 94% of the patients. So if we see what antimicrobial should be given for what organism, so this is the list: Campylobacter, azithromycin; Clostridium difficile, vancomycin; non-typhoid Salmonella enterica usually does not require antibiotic. Salmonella typhi or paratyphi, you can treat with ceftriaxone or ciprofloxacin. Shigella again, azithromycin or ciprofloxacin. There are some alternatives available as well. Vibrio Cholerae with doxycycline. Non-Vibrio Cholerae usually not indicated for non-invasive disease. If there is an invasive disease, non-Vibrio Cholerae, you need to treat with ceftriaxone and doxycycline. Yersinia again, an uncommon infection. It's a cause of chronic diarrhea usually. It's treated by trimethoprim sulfamethoxazole. For parasitic infection, if it's Cryptosporidium, you treat with nitazoxanide. Again, usual dose is 500 milligram BD for a period of 3 days. Giardia lamblia, again, you treat with nitazoxanide or tinidazole. Cytoisospora belli, trimethoprim, sulfamethoxazole, trichinella species again uncommon with albendazole. So once you have decided to give antibiotics in specific scenario, we need to know the dose. So what one needs to understand that this is one of the diseases where even a single day therapy may be sufficient. So levofloxacin, again, single dose you can give 500 milligram. If the patient does not respond to a single day therapy, you can extend the duration for a period of 3 days. So that's very important to know. Ciprofloxacin, if you're giving in a single dose, 750 milligram or 500 milligram for a period of 3 days. Again, azithromycin, single dose, 1 gram, or you extend the course for a period of 3 days, 500 milligram per day. Rifaximin, again, the dose in this acute diarrhea is less. This is 200 milligram 3 times a day for a period of 3 days. So azithromycin primarily for fluoroquinolone resistant Campylobacter or resistant enterotoxigenic E. coli. It's preferred for dysentery or febrile diarrhea. And rifaximin should not be used if there is suspicion of Campylobacter, Salmonella, and Shigella. So this chart sums up whatever I have said. Importantly, what you need to see here is whether the diarrhea is watery or it is dysentery. So dysentery, as I mentioned, typically is the presence of blood in the stools. If the diarrhea is watery, then you need to see whether the patient is having mild illness or moderate to severe illness. So mild illness, only hydration, and the mild illness is defined by no change in activities. That obviously means that the disease is not severe, not too many stool frequency, and no other significant problem as such. Moderate, again, the patient is able to function, but with forced change in activities. This is what moderate disease is. Again, this is very subjective, but this is what the guidelines mention. Severe is, again, total disability to do anything. So that's severe disease. So if it's moderate to severe disease and if it's travel associated, you need to give antibiotic. Again, important. So history again becomes very important. If it's non-travel associated, you need to look for the presence of fever, a high-grade fever more than 101, persisting for a period of more than 3 days. The patient should be considered for microbiological assessment and empirical antibiotics. If the fever is low grade, you can again consider only anti-motility drugs, that is loperamide. If it's dysentery, then you again need to see whether it's travel associated or not travel associated. Once it's travel associated, you are resorting to empirical antibiotics. Usually it's azithromycin. And if it's non-travel associated, you can consider doing a microbiological assessment before you resort to giving antibiotics. Again, as I have highlighted what mild, moderate, and severe disease is. So coming back to this, after having understood this very, very important chart. So same, this patient, 30 male, immunocompetent, you can see what I have written. So what do you think? This patient needs antibiotics or he doesn't need antibiotics? So that's doesn't reflect good on my part actually. So you see there is a history of travel. What I have written is able to function, but with change in activity. So that means a moderate disease. Is that clear? The patient is having moderate disease for sure, though no fever, but a history of travel. So obviously you need to give azithromycin for this. If again there is no history of travel, you can just resort to loperamide and do nothing else. So I think it's important to this is again American Journal of Gastroenterology 2016. You can see this chart again and memorize what needs to be done. Okay. So the other important condition that we commonly see in gastroenterology is cholangitis. So cholangitis is biliary obstruction, usually because of stones or malignant disease. So pain, fever, and jaundice is the typical triad of cholangitis. So coming to the question straight away, this is a 40 male, pain abdomen for 10 days, fever for 2 days, jaundice for 2 days. On examination, there is icterus, mild, Pulse rate of 100, temperature of 100 degree Fahrenheit, respiratory rate almost normal with a normal blood pressure, that is no organ dysfunction. TLC of 7,000, bilirubin of 3 milligram per deciliter. So all these show that the patient is having fever without any organ dysfunction and not a very high counts in the normal range. Ultrasound shows gallbladder stone with dilated bile duct with a stone. Diagnosis is GB gallbladder stone with CBD stone with cholangitis. So does this patient need antibiotic? I can see some gastroenterology residents also. Okay. Antibiotics? No antibiotics. So I think we'll just come to the answer again. But this patient, any patient with cholangitis, does need antibiotic. There is hardly any doubt about in that. So that needs to be very, very clear. The duration of antibiotic, which antibiotics should be given, other questions we'll try to answer, along with how urgent is to perform the therapeutic procedure in such cases. So this is a common scenario in our ward. Patient comes in the night with cholangitis. The question that we ourselves ask whether we should go ahead and do a biliary drainage straight away, or we can wait for some time. So if you see the microorganisms in acute cholangitis, you see the E. coli and Klebsiella form the predominant organism. This is 35 to 62% in the blood cultures. And again, a significant proportion is constituted by Klebsiella. Other uncommon organisms, Pseudomonas, Enterobacter, Ciprofloxacin, and again, a significant proportion of anaerobes. So very, very important. Once we are dealing with cholangitis, we need to cover for anaerobes as well. They constitute around 15 to 20% in blood culture and approximately similar in the bile culture as well. So factors, antibiotic activity against causative bacteria, that is the one that is required. Severity of cholangitis need to be seen, which will see how the cholangitis severity is graded. Presence of renal hepatic disease, we need to consider past history of antimicrobial administration. So commonly what happens, the patient comes from outside, he has already taken an antibiotic, counts are still high, fever is not settling. If you don't see those antibiotics, you will just end up giving the same antibiotics again, which does not make any sense. So local epidemiology and susceptibility data, as everyone mentioned, but it's very difficult to keep that. Every hospital should have their antibiogram. Biliary penetration of antimicrobial agents is the thing that you need to consider. History of allergies and other adverse events to antimicrobials. And the timing of antibiotic therapy, again, if there is shock, antimicrobial should be initiated within 1 hour. For others, maybe 6 hours. So there is no reason to delay the addition of antibiotics. It's usually given for around 5 to 7 days. However, if there is a gram-positive enterococcus or streptococcus, usually it is continued for longer, which is 2 weeks. And if the obstruction persists, treatment is continued. If for some reason you are not able to relieve the obstruction, then obviously you will have to give antibiotics for long. In liver abscess, treatment until resolution of abscess. So if you see the antimicrobials with good biliary penetration, the first generation Pezolin, second generation Cipotiam, third and fourth generation, again, the commonly used that we have in use in award, ceftriaxone, ceftazidime, and cefoperazone sulbactam. So these are the common drugs that we use, have a good biliary penetration. Among chloroquinolones, ciprofloxacin, tazofloxacin have got good penetration, monobactams, astronam, and clindamycin. Okay, so I don't know how it does. Okay. So this is bad. Okay. So this chart does tell you about the grading of cholangitis. That I want to emphasize is, once the patient is in cholangitis, obviously you need to give antibiotics straight away. Grade 3 cholangitis is when there is organ dysfunction. That is grade 3 cholangitis, neurological dysfunction, cardiovascular, respiratory, renal dysfunction, hepatic dysfunction, which is defined by prothrombin more than 1.5, or hematological dysfunction and the platelet count is less than 1 lakh. The grade 2 cholangitis, that is moderate cholangitis, is defined by a high TLC of more than 12,000 or a leukopenia, high fever, total bilirubin of more than 5, presence of hypoalbuminemia. The grade 1 cholangitis does not meet criteria either for grade 1 or 2. So what does that mean? That means if the patient is having grade 1 cholangitis, comes in the emergency on Saturday, you can wait till Monday to do the procedure. If the patient is having severe cholangitis, even if it's Saturday night, you will have to do the procedure. That is ERCP or a PTBD, that is the biliary drainage. So this is what the chart indicates. Grade 1 cholangitis, mild, antibiotics can do the job. And whenever feasible, you do a biliary drainage. Grade 2 cholangitis, antibiotics and general supportive care to begin with. Early drainage. Grade 3 cholangitis, urgent biliary drainage. So urgent biliary drainage may be less than 6 hours. You go ahead and drain the biliary system. So antimicrobials with high prevalence of resistance among Anterobacteriaceae. So this is the list where now these have high resistance. So again, coming back to the question, you have seen this patient is having cholangitis. The only thing that I want to highlight, this patient has grade 1 cholangitis, not having organ dysfunction, not having high counts, not having high bilirubin, that is bilirubin is less than 5. So this is mild grade 1 cholangitis, where you can wait for the biliary drainage to be performed. And what antibiotics, the ones that we have discussed, having good biliary penetration, usually covering for anaerobes as well, and the duration should be around 3 to 7 days. For cholecystitis, the microorganisms are almost the same, and the antibiotic selection is similar to that for cholangitis. So coming to the third, again, very, very important scenario. Again, at least in our ward, maybe around 20 to 30% of the patients are always of pancreatitis. So a 45 male chronic alcoholic, severe pain in the epigastrium for 4 days, fever for 2 days. On examination, a high pulse rate, febrile, high TLC, high creatinine, that is renal failure, CT showing necrosis. So CT ideally should be done after 3 days if required. So 50% pancreatic necrosis with collection. So diagnosis acute severe pancreatitis with renal failure. So does this patient need antibiotics? So this is again day 5th of pancreatitis. Yes, no? Yes. So then I can continue then. Okay. So, so I think this is a very, very common scenario, and I can tell you all our colleagues which are practicing outside, once these patients come to them, by no means they are able to hold back or not to give antibiotics. All of them uniformly give, but what needs to be done or what is ideal, I'll come to that. So the role of antibiotics in acute pancreatitis are very, very clear. These studies, there are a number of studies, and these are the latest guidelines 2018 published in a very reputed journal, Gastroenterology. So it clearly suggests that one should not be giving prophylactic antibiotics. So prophylactic antibiotics, no. Why? Because instead of doing good, they may do harm. So that is a problem. So if it's not doing any harm, even then you can think of giving it. But they have got no role on single or multiple organ failure. They have got no role in preventing the duration, decreasing the duration of the stay. In fact, there are studies which show that giving these can lead to increased risk of organ failure. So that is a problem. When should they be given? So they are indicated for an extra pancreatic infection. If you find presence of cholangitis, if you present UTI, if the patient has got pneumonia, then they are indicated. But only because the patient has, in the first week of pancreatitis, if it's just the presentation that I just showed you, that is typically known as systemic inflammatory response syndrome, and there you may not need any antibiotic. Infected necrosis should be considered in patients with pancreatic necrosis who fail to improve after 7 to 10 days of admission. So what is this infected pancreatic necrosis? As I mentioned, there was 50% necrosis in this particular patient. So in the initial 7 days, you assume that all this necrosis is non-infected, and high count fever are possibly because of systemic inflammatory response syndrome and not because of infection. Usually by the end of 1 week, this decreases. Systemic inflammatory response syndrome response dies down, and then you have the onset of infection predominantly in the 2nd and 3rd week. So that's the time, if the patient is deteriorating, you need to consider that it's possibly infected necrosis of the pancreas, and you need to give antibiotics. So in infected necrosis, you can choose to do an initial CT guided FNA for gram staining and culture. Theoretically, this is given in the guidelines. Practically, no one does this. Empirical use of antibiotics once you are suspecting infected pancreatic necrosis after a period of 7 to 10 days, and you need to stop if you get all cultures, blood cultures negative. In patient with infected necrosis, the antibiotics that you commonly choose, carbapenems, quinolones, and metronidazole. These are useful in delaying or avoiding intervention. So what are the intervention needed? Primarily, what you get in these patients is either a presence of pseudocyst, that is a clear fluid without debris, or the presence of walled off pancreatic necrosis, which is a fluid with necrotic material. Again, routine antifungals not recommended. You should not be giving in the initial 1 week or 10 days. So this was a study which clearly showed that as the percentage of necrosis increases, the chances of infection again increases. So that's a uniformity in this. So if it's a mild pancreatitis and no necrosis, then the chance of infection is highly unlikely. So when do you give antibiotics? When there is an extra pancreatic infection in the form of catheter sepsis, urosepsis, or cholangitis. Prophylactic not given, sterile necrosis not given. You give an infected necrosis usually after 7 to 10 days, and routine antifungals not indicated. So what are the common organisms that you get in these? E. coli, most common, and Pseudomonas aeruginosa, Staph aureus, Klebsiella, Proteus mirabilis. So these are the microorganisms that you commonly get in patients with pancreatitis. Okay. So these are the antibiotics with good pancreatic penetration: cephalosporins, quinolones, carbapenems, and metronidazole. So coming back to the patient, if you see, does this patient need antibiotic? No, this patient does not need antibiotic. 5th day of illness, and this patient has got features of systemic inflammatory response syndrome. You can wait for some more time before resorting to antibiotics once you think of infected pancreatic necrosis. So I think, ma'am, should we stop? I think. So I'll just come spontaneous bacterial peritonitis. I'm skipping because I think they have exhausted 20 minutes. So just take home messages. Most acute diarrheal episodes are self-limiting, no antibiotics. Empirical antibiotics, specific situations after stool culture. Acute cholangitis and cholecystitis need antibiotics. No role of prophylactic antibiotics in severe acute pancreatitis. Spontaneous bacterial peritonitis that I haven't covered. Usually the standard treatment is ceftriaxone that we commonly give. If somehow the patient is resistant to it, we usually resort to piperacillin tazobactam. Thank you.